Okay,
Can you
great.
see? Yeah.
Yeah, perfect. So thank you both, Joe and Joe. So welcome officially to this member webinar. It's called Raising axSpA Awareness and Education for HCPs. And well, it's about time to have this type of webinar because the delay to diagnosis campaign and all the work that's being done has showed us that this is one big barrier to actually the delay of diagnosis. So it was about time. And without further ado, if we go to the next slide, please, we will again, I'm going to repeat a little bit about the house rules. So muting ourselves is going to be a really good idea. And then moving on, uh, uh, it's a good idea also to say hello in the chat. I can see there's a little bit going on in the chat already. If you can state your name and where you're from, your organization and country, this is a really nice way to get networking or just saying hello and like just really getting to know each other. And of course, you can ask questions in the chat or raise your hand and we will invite you to speak. But this can be done really good at the end of the presentations. So Q&A will follow or free presentations. So without further ado, and we will start off with Dale Webb. He's the Chief Executive Officer of NAS, the National Axial Spondyloarthritis Society from UK. And the next presentation will come from Brenda DeLauder. I hope I'm not ruining the name, who is also the Executive Director from Canadian Spondyloarthritis Association, from all the way from Canada. And then from the lovely Miranda Van Dam, who is the chair of and the founder of Axial Spondyloarthritis Association from the South Africa. So they do have some great examples to share with us regarding the theme today. And you can use these examples as inspiration and maybe ask them at the end or maybe find them afterwards. Their slides will be uploaded on the ASIF website and find them afterwards and discuss with them about what you can do in your countries and raise awareness among HCPs. So Dale, you can like start and let us hear what you've done are raising awareness among HCPs. Thank you all and enjoy the presentation.
Thank you so much for the introduction. Can you all see my slides? Yeah, great. Okay. Well, I'm delighted to be invited to speak at today's session. And in thinking about this topic, it seems to me that what we're trying to do here in educating healthcare professionals, we're trying to win hearts and minds and change both clinical practice and healthcare policy. So our starting point at NAS has been to think about the range of strategies that have been used in the literature to create change. And there are, of course, numerous strategies. From the health education and the addictions literature, we have numerous behavior change models, particularly aimed at individuals, to help us think about how you get individual clinicians ready for change in their practice with regard to axial SPA. More systemically, we have a literature that looks at how do you spread new ideas through a social system over time and use that to design strategies to promote the adoption of beneficial innovations. We also have some great work in the social movement theory and social movements from the 1960s. How do effective groups organize and act collectively to address injustice or create social change? And of course, there are many other models, but I will try and draw in relevant aspects that have informed the work we're doing in NAS to reduce diagnostic change. So I want to focus on this Everett Rogers model from 1962 called the diffusion of innovations. It's used globally as a change model. And what he argued was, in a typical population, with the introduction of any new technology or idea, there will be 5 distinct population groups. First, you have the innovators, the people who have got the first people who've always got an iPhone or a Fitbit, or the first doctors who are doing digital consultations, the people who are always there when there's a new idea, a new shiny thing. They're quickly followed by the early adopters who see the innovators and want to be part of the change which is occurring. And then it gets more challenging, what's called the chasm, the gap from the innovators and early adopters to the 2/3 of the population in the middle, the early majority who are a little bit skeptical, and then the late majority who are much more skeptical. And then even harder to change at the end are the 16% of the population who just want things to stay as they are. How useful is that as a change model to think about developing strategies for diagnostic delay? I think it's very helpful. So let's talk first of all about innovators and early adopters. So innovators are the first people to develop ideas and adopt innovation. They're also risk takers. Early adopters are opinion leaders, they're in leadership roles, they embrace change opportunities. And both innovators and early adopters are well-networked individuals. And in our sphere, these are rheumatologists who will know all the secondary care professionals, who will know the leading figures in primary care, very well networked across healthcare systems. And in terms of strategies to engage them, these kinds of people, they enjoy being visible. They like being on speaker platforms. They like sharing their work on their social channels. They like publishing in scientific journals. And any educational process to engage HCPs really needs to start, in my view, with these people, with cultivating deep relationships because of who they are, because of the opinions they hold and the respect they have, and because of their networks. So in more practical terms, so for us at NAS, for example, when 5 years ago we first established within Parliament a parliamentary group on axSpA, we deliberately brought into those early meetings the pioneers and early adopters, people who are at the leading edge of thinking about how do you reduce diagnostic delay. And when we're trying to get platforms in national conferences, ensuring that our senior leaders, they're up there promoting the work that NAS is doing, making the change, making the case directly to their other healthcare professional peers, why they also need to be part of our movement for change. And of course, for us also, partnering with those innovators in publishing in high impact journals, making the case for early diagnosis. And these early adopters and pioneers are amazing collaborators. So for example, 3 years ago, we wanted to create a new national patient survey to measure accurately and systematically the time to diagnosis. So we collaborated with this amazing group here of healthcare professionals in rheumatology who were so eager to create a national patient survey tool and then to work with us to spread the message about why other departments would want to join it. And so far, 50 rheumatology departments have joined this survey. We created a group of champions in primary care. We gave them leadership training. We gave them training in using quality improvement methods. And we worked with them to create resources at national level to give us greater clinical visibility for axSpA in the primary care community. They tested out interventions at local level. They created new resources that are targeting the primary care community. And those primary care professionals have been promoting the NAS symptom checker. So widely now, more widely in primary care, those professionals are now aware of and are encouraging their patients to undertake our online checker. Likewise, we're piloting some new work in primary care with 16 general practices in England to use a pop-up tool on the primary care information system to tell the GP when that patient in front of them may have axSpA. So engaging these early adopters in a range of collaborations is so important. But for us, the set piece, if you will, the star of our show, has been a program we've been running since 2019 called Aspiring to Excellence, that is working with 23 rheumatology departments to create change, to educate healthcare professionals, to change clinical practice. And so we've taught them the theory and methodology of quality improvement. We've taught them how to collect the right kinds of data, how to make the business case for improvement. We've produced podcasts and case studies from all of that to help us make the case for change. But importantly, we are creating a very visible sense of a community creating momentum to change the time to diagnosis. These teams come together with us in national conferences. They share their local service improvement projects. They share their data. We give them a platform to talk about their innovations on reducing time to diagnosis. We get them to share their data showing how time to diagnosis is reducing as a consequence of the new innovations they're putting in place. And we increasingly at NAS talk about building a social movement for change. Now, please ignore the detail in the chart. The important point is the map of the UK, where we're showing where our various programs on diagnostic delay are working across the UK to give a sense of growing momentum and of spreading this work right across the 4 nations. As I mentioned, pioneers and early adopters are very visible in social media channels. They'd like to be on platforms, but also recognizing their work is so important to us. So we created a Change Makers Award aimed at healthcare professionals who are doing brilliant work on diagnostic delay. We have awards at bronze, silver, and gold medal at gold level. We present the awards in Parliament. Their members of Parliament come along. It's a way of saying thank you, but again, creating a visible community of clinicians who are creating new momentum in educating others and reducing diagnostic delay. And in addition to the formal resources I've just talked about, there are informal things we do too. We have an online network of more than 170 healthcare professionals that meet up and provide support to each other on local challenges around education, service design, etc. We have a whole YouTube channel devoted to our peer-to-peer network. And we have a great online resource, a toolkit for any healthcare professionals who want to do work on diagnostic delay. So back to this chasm, how do we move on if we want to educate healthcare professionals from the 16% of the population of healthcare professionals who are innovators and early adopters? How do we target the 2/3 in the middle? Well, early majority, they are really leaders, but they do adopt new ideas before the average person. But they need to see evidence that the innovations we're doing have worked before they try it. And the late majority, well, they're quite skeptical of change, and they will only adopt an innovation after it's been tried by the majority. So 2 important strands to our work to target the early and late majority. First, the evidence. We've been working hard to bring all of our data over the last 4 years into specific scientific journals to target different communities. We've published in the Rheumatology Journal in the UK all of our data on our public awareness campaign and our work to reduce time to diagnosis there. We've just published in the main international primary care research journal, which is the British Journal for General Practice, all of the arguments, all of the resources for primary care professionals. We've published in clinical radiology all of the latest evidence and our work in relation to educating radiologists about axSpA. And then the big one for us, which we're just publishing now in the Rheumatology Journal, is an economic model of the total cost to our economy in the UK of diagnostic delay, which we estimate at £3.1 billion or 3.7 billion euro per year. And now what we're doing is going further than this, because now what we can do is to take the data that our individual pioneering sites have been creating with us, showing their reductions in time to diagnosis. We can input that into our economic modeling tool, and we can estimate for individual local areas what the savings have been. So here in one place in England called Berkshire, where they've achieved the gold standard time to diagnosis of just 12 months, the economic model estimates that saves their local economy 171 million euros per year. Now, those kinds of big figures are then get the attention of policymakers and it also helps those healthcare professionals at local level make the case to their NHS organisations for more investment of resources in work to reduce diagnostic delay. I mentioned that we've had an ongoing survey for the last 5 years. We've got 600 patients who've been diagnosed since January 2021. And just to clean up this chart into this, we now think we're at a tipping point in the UK. We think we're seeing for the first time a reduction in the time to diagnosis. And this is important for us, crossing the chasm and now targeting healthcare professionals, that early and late majority, to say to them, look, this is happening. You have to be part of that with us. So how do we do that? So in the final part of my presentation, we have just launched something we've called a national playbook for axial SpA diagnosis. It brings together into a single resource all of the data, the evidence, the case studies, the guidelines into a checklist which follows the patient from symptom onset right through to diagnosis and guides the professional on what they need to do. And again, it's based on behavioral insight theory. It's easy to understand. We've created it in a format which looks like National Health Service documentation, so it's familiar to healthcare professionals. We're using our social channels to promote those who are involved in it, and it very much links to 2 national goals that we've launched at NAS about diagnostic delay. I'll just show you 2 examples very briefly. This is a part of the playbook where we make recommendations on the measurement systems that rheumatology departments should have in place. We propose for the first time in the UK specific metrics that should be in place in rheumatology. We offer guidance points, tools they can use, and case studies of rheumatology departments that have been doing this already to say, look, we have the proof of concept, we have the data, it's okay, you can do this too. And here's another page on primary care. We estimate the 5 areas for good practice in educating GPs about axial SpA. Again, links to tools, links to case studies of where we've been doing this successfully. And as we launched this at the conference just a few weeks back, part of our social media promotion is saying, look at these leaders now across the NHS who are being part of our campaign for change. And so in my final slide, for us now, the real prize, and it's just happened to us this week, is that we've had confirmation from the National Health Service. They are going to co-badge the national playbook with NAS in a program called Getting It Right First Time. This means that all of our resources, all of our arguments about diagnostic delay will become fully integrated into the healthcare system in England. And this for us is the major thing we can have achieved really, to make sure that the majority of healthcare professionals in rheumatology and elsewhere are now working to reduce diagnostic delay. Thank you for listening.
Well, Dale, thank you so much for this presentation, which was, well, for one, I'm really happy to hear that there is a change. And this is so, well, I'm not going to go into comments now. I'm going to move on to the next presenter, which is Brenda DeLoader. And I'm going to, because we need some room for comments and questions at the end, but I do have comments and questions. So please, let's hear from Brenda. And we're very happy to go to your presentation. So yes, thank you.
Can everyone hear me?
Yes, really well.
Okay,
thank
great.
you.
Wonderful. Well, thank you for the opportunity to share a little bit about what's happening here in Canada. So I wanted to start with sharing that we've got a 7 to 10 year wait time. We have over 500,000 Canadians living with axSpA. And here in Canada, we're really looking at 4 initiatives to address the delay to diagnosis as well as treatment and care. So the first thing I'm going to talk about is the axSpA National Back Summit. Then I'm going to move into very briefly 3 other components, which is the patient partnerships, continued medical education, and urgent care protocol. So in the next few slides, we talk about this back summit, which is just around the corner for us. It's slated for June 23rd. And what we wanted to do was optimize all of the touch points that the individual experiences prior to diagnosis. And here in Canada, diagnosis primarily lies within the family physician and the rheumatologist. However, we know that Canadians are relying on allied healthcare professionals to help them cope with their pain for up to several years leading up to their diagnosis. So there's really an opportunity to bridge the gap in support for healthcare professionals working with those individuals not yet diagnosed, ensuring that they have the resources and the tools to consider axSpA. Now, although they cannot offer a referral to a rheumatologist here in Canada, we really wanted to help them identify the possibility of axSpA and then empower the patients. So we're doing this through this summit. And the goal is to co-create recommendations to reduce that delay and to also identify system barriers. So as components of this summit, we have educational tools and pre-reads to help them prepare for the event. So we really see allied healthcare professionals as a gateway to this earlier diagnosis. And even small changes and enhanced education can really help to serve the patient. We are working with two of Canada's top rheumatologists who are keynote speakers and presenters at this event. And one of the things that they were concerned about when we were first talking about this was for chiropractors, for example. This is, their business model to serve patients and their clients, so to speak. And would we be taking business away from them? But we decided to forge through that and really say to chiropractors and those who have their own practices, healthcare practices, that we want to invite you to be a part of this solution in earlier diagnosis. And we're really going to map out the patient journey and all of the touch points that an individual encounters prior to diagnosis. At the end of the summit, we will be producing a national publication where we will be featuring those participants in the document. And we're going to move this forward with policymakers as well as educational institutions to talk about, okay, what role can allied healthcare professionals play in the earlier diagnosis? During the summit, we're going to have some breakout sessions, and we wanted to keep this really simple. We wanted to keep it highly focused. And so here are the 4 components that we will be working through during the breakout sessions. Reflection upon the patient journey, and to have those healthcare professionals identify what is relevant as it relates to their practice and to their work. We're also going to dig into what they see as key barriers that delay the diagnosis. We're also going to be discussing what are the opportunities to increase awareness and consideration of axSpA. We have here AS/axSpA because that is the language that many healthcare professionals are using. So we're going to be combining both of those acronyms here, even though internally at the CSA, we are committed to using axSpA. So we wanted to use a language that's potentially most relevant to the participant. And then finally, how can we empower patients to take an active role in their journey? And this is really important because, as I mentioned, allied healthcare professionals do not have the opportunity to provide a referral directly to a rheumatologist. So how do we empower the patient to go back to their family physician who has that potential for a referral, and so they can play that active role? This is my final slide here. I wanted to touch on 3 other initiatives that we are actively working on here in Canada to really focus on that delay. So we have what we have call patient partnerships, and this has been a pilot for us. So we have individuals who are diagnosed with axSpA, and they have been presenting at medical schools as well as grand rounds at the hospitals. So this is an opportunity to engage our volunteer base. And it's also an opportunity to really look at the root cause of the delay to diagnosis with the primary healthcare physician, the family doctor here. So even though we are still trying to influence the curriculum, by having a patient speaker at the medical schools, this is really giving a personalized and high impact opportunity for those medical students to learn about axSpA directly. The other initiative that we just launched, and this is with respect to continuing medical education, so CME. We had talked a lot about having and creating our own program. However, the barriers to doing that in Canada are quite restrictive. So what we did is we aligned with a government program for continuing medical education for family physicians in particular. And they are now offering 4 sessions per year on spondyloarthritis and axSpA. And they are promoting the CSA as resources and promoting our tools as part of that. So really leveraging and optimizing an existing program and partnering with an existing program for continuing medical education. The third, and this is hot off the press, and this is my final component here. Just last week, we met with the Ministry of Health to talk about emergency protocol. Now, this isn't specific to the delayed diagnosis, but this is specific to ongoing treatment. So I thought I'd include this, just inject it in here quickly. And we're looking at, and thanks to our friends in America who have this protocol, we're going to be leveraging their tools to Canadianize the emergency protocol. So, and this will be for hospitals as well as EMS team members. And so we're going to be adopting training and education for those individuals. Thank you very much.
Well, Brenda, that's amazing. Thank you so much for this presentation also. And this kind of combines well with the previous one in terms of you are like, it's amazing how you are also partnering with patients to do to promote awareness, and it's really nice to hear that. And let me remind you briefly the housekeeping rules. Please mute yourself throughout the presentation. It's easier for everyone to focus and pay attention. And let us hear now from Miranda Van Dam from ASASA. And let's move on to her presentation so we can have a little bit of time at the end to hear questions and maybe some comments. Thank you. So, Miranda, when you're ready.
Hi there, sorry guys, I just had a bit of a technical glitch there. Good afternoon. We are thrilled to have been invited by ASIF to share the journey that we've tried, you know, the footsteps in our organization, as we only literally found out 2 years ago of the massive delay in diagnosis. We have been able to do a deep dive into it to try and understand where the delay in diagnosis is. We clearly understood from literature and other patient organizations that the delay could be twofold, on the patient side, of course, and then we realized in this massive journey that a patient goes through, there's definitely a delay on the HCP side of things. Following our IMAS results, we really spent some time to try and understand how it's even possible for a patient to take 11 years to find a diagnosis. And from what we could see in our results, this was directly due to patients being sent from pillar to post. This is not new news for any of you, but we decided to first just stick our finger in the water and see, you know, see if what we were thinking is true was actually happening. We got together a small group of HCPs, 15 doctors, in a conference room. We intensely trained them for 2 hours and on the disease area. What we realized during this small pilot project we ran is that not one of the HCPs in the room was even aware of our disease. We also realized that there was a massive lack of airtime when HCPs are trained, where they're spending more time on the smaller diseases and less time on the bigger diseases and less time on the smaller diseases. But what we were not prepared for was the diagnosis that happened after following 3 to 6 months after the seminar, we diagnosed 45 patients after the seminar by a group of 15 doctors. That is when we realized that what we knew was true, and we can actually try and roll it out. Our biggest dilemma, of course, was funding. We literally had no funding available. It's such a new concept in this country, and with the different role players. And we knew we wanted to focus on this odyssey. We knew about the patient odyssey, and we knew that we were wanting to target as many individuals that touch these patients' lives before they get diagnosed, spending no money at all. I think you're all very familiar with this slide. I think all of us have even used this slide in most of our presentations. But what we needed to understand is, besides the patient being diagnosed at the end, what were these comorbidities that the patient was coming up with? The obvious back pain we know is obvious, but the smaller details in the disease is what we really needed to understand to identify in our country who were the healthcare professionals that touched our patients before they got diagnosed. So we immediately almost got an action plan together and said, these are the guys we're going to focus on. This is what we know. This is what we know is true from what our patients have told us, and we knew that we now had a print of how we're going to go forward. The carbon copy in South Africa for us were definitely these 6 speciality areas, which we knew we would focus on. And this is in South Africa, the pathway of our patient before they get to the rheumatologist. They would go to the pharmacy for back pain, or they go and see their physiotherapist, maybe end up at the GP. But this was the majority pathway touch points in South Africa for patients that we could see. What we then started doing immediately is we started identifying all the major associations and societies in South Africa that speak directly to these speciality fields. And we very quickly got into started communicating with them up to a point where they agreed to meet us, where we had extensive webinars with them, where we could show them patient videos of what happens when a patient's diagnosed, and almost make them feel a sense of the role that they play in this delay in diagnosis, and almost a sense of responsibility of wanting to step forward and changing this at their level. The magic really started happening for us after this, because there wasn't one of these meetings that we did that the association involved with those specialists did not agree to A, grant us a webinar with all of their members, B, not charging us a cent for it, and C, handling all the administration and invitations of it. So in South Africa, we have what we call a CPD. So this is a course that professionals need to do every year. And this basically keeps their registration up to date and their renewal every year. So if a healthcare provider or physio or whatever specialist do not attend these specialized programs every year, their qualification do not get renewed. So this was exactly the kind of courses that we were now going to start doing, because as soon as you present a course to a healthcare provider and it's CPD approved, they almost have to go. So this technicality in the South African health system almost gave us a little secret key to a lock that we could unlock that could ensure huge audiences. So how did we do the course? So the course is a 90-minute webinar, and it's a quick detailed crash course into what axSpA is. We would normally start it with a patient voice. That would roll over into to a rheumatologist who would give us the clinical view of the disease and all the comorbidities that goes with it. And then it would be tagged by a physiotherapist that would explain the role of movement and flexibility with patients. What does it cost us? Nothing. And what if we spend on it? Nothing, which is quite remarkable. So this is just a quick tally of numbers to show you what we're trying to do and what we've done now in the last year. So this is the target groups that we are focusing on, and this is also these webinars that we're involved with. So trying to get to these specialists without spending a fortune, traveling all over South Africa, but getting the key information to the places that we need to get. And I think lastly, we're quite proud to show you that I think we can see in the growth of our membership that there definitely has been an impact. If we see the growth of our patients finding the association from 2023 to 2024, we literally haven't done anything else but this training in the space of delayed diagnosis. And we can definitely see that the patients are getting to the rheumatologist quicker, and that's what's leading to the growth in our membership organization. And although our program is still in baby shoes, I think there's a massive scope for us to continue, and we're very excited to share more results with you guys as we go along.
Well, that's amazing to start. I mean, and at the end of the day, that's all we want. Let me again remind you, please mute yourselves in order not to have this back end voice. Thank you. That's all we want to like close the gap and the delay to diagnosis to stop being so big in times and like to have better results. And now it's the time to open up for questions, comments from everyone that's in the call. Do we have any? And you can just raise your hand, join in.
There's a couple in the chat, Nadia.
Yeah,
there's one from Peter. He said, I think this is directed to Dale. Not knowing any better, I'd consider Berkshire a well-off part of the UK. If true, do you believe that made a difference in reducing time to diagnosis?
Hi, Peter. Yes, that's a lovely question. It's hard to know for sure. I would say two things. One, for me, I think what it is critically important, reducing time to diagnosis, is the quality of the leadership in the rheumatology department driving service improvement. Without really stellar leadership connecting to primary care and secondary care and being the glue that holds it all together, you won't succeed. With regard to areas of high deprivation, what I can say is this: a year ago, we did a 6-week public awareness campaign in Belfast in Northern Ireland, high levels of deprivation, as you may know. And that 6-week campaign, we were able to reach 1 million people. And that was 81% of our demographic, which was 18 to 14-year-olds, in a campaign that talked about broken dreams, didn't talk about axial SPA so much, talked about lower back pain, push people towards the symptom checker. Now, we didn't collect data on deprivation specifically, but my hunch is that kind of campaign was successful across the board. Will deprivation have an impact overall? Of course it will. But I think for us as patient organizations, we have to pick the lowest hanging fruit and use the data and make the case, and yes, it'll be easier in some places than others, of course, but at least having those examples will help, I think, to stimulate change.
There's a question, Nadia, also from Sophia. I don't know if, Sophia, you want to speak?
Yes, thank you, Joe. I was just wondering, because I'm sure that the HCPs or actually general practitioners get a lot of requests from different therapeutic areas. So how do you get their attention? And just going to Dale's curve of, innovators, I'm sure that among the GPs as well, there are the ones who are not so easy to approach to get them involved in, continuous medical education. So it's just a question, what are the experiences? And this is to actually all presenters. And thank you for the wonderful presentation and the great work you are doing. So what's your experience? How can GPs get, excited about this? How do you involve them?
I think if I could go first, in South Africa, certainly we, with our campaign, the use of real life patient stories that tells the whole story of the journey of the patient. I mean, people can't believe the stories, and through a real story with a real person and a real face for us, we could touch their hearts very quickly, because that was all felt immediately guilty. That sounds terrible, but you could see the part that they played in this delayed diagnosis. For certainly, Dale, I think your experience has been slightly different from ours, but definitely on our side, it was that story of that person and this road that they're traveling.
Shall I come in next? Sophie, it's a great question. And we're starting from, oh my goodness, we've got so much to do. One of my GP colleagues was speaking recently at a primary care conference. She was talking about axSpA diagnosis. There were 200 GPs in the room. She said, put up your hand, please, if you've heard of the phrase inflammatory back pain. 200 GPs, only 5 of them raised their hand. I'm not sure how it is in your countries, but in the UK, that's where we are. So I would say 3 things. 1, having clinical leaders championing for axSpA, as our colleague did, speaking at those national conferences. And we're targeting the Royal College of GPs conference this year with a presentation and a corporate stand and a GP talking directly to the GPs. So trying to create clinical visibility and leadership is first thing. Second thing, the evidence about primary care. So we've now got data from our patient survey showing that 53% of the time to diagnosis is spent with patients stuck in primary care, bouncing around with multiple presentations. And our data say it correlates that patients who have had multiple GP presentations are more likely to have a longer time to diagnosis. Now, if you present that to a primary care audience and say, look, the business case opportunity for you is, if you spot that patient at their first presentation, you're going to free up appointments for other patients. So using the data and making a business case out of it is really important. But then thirdly, promoting the range of digital solutions that get axSpA higher in the clinical consciousness of a GP. I mentioned the pop-up tool we're trialing. In the chat, I've put a reference to a tool called the SPADE tool. Now, our colleagues in Belfast a year ago did training of 100 GPs. None of them had heard of the SPADE tool, but they all said, my goodness, what an amazing tool to help us. So these are often very simple technologies that we can promote to the primary care community that I think will help to raise axSpA in their consciousness. But there's no overall single fix. I wish there were.
So
if I could,
Annie has raised, sorry, I thought Annie had raised her hand, but you can go, I mean, it's either one or the other. We can hear both of you, one after the other, please.
Okay,
yes,
I'm not sure if I'm next.
Yes.
Oh, thank you.
Yes, please, Annie, and yes, then Brenda. Sorry. Yeah.
Okay. I just wanted to comment on something Brenda brought up, which is where I go to one of the universities here. I've been doing it for a very long time, and give a lived experience to the first year university students for medical. So these are GPs in their first year. And I've been doing it for a while, but also I've done it with physiotherapists and osteopaths and myotherapists and somebody else, and a couple of universities. And we found the overall impact of those students at that time was incredibly high. And since that time, my local GP is a trainer of GP students. And I've come across 3 students that have come through the stream that have seen me do the presentation 5 years earlier. And their impact has been phenomenal. They just could not believe they could see a person with such severe ankylosing spondylitis, and the story and the journey that I've had, which some of you know is like over 20 years to get diagnosis correctly. The second thing was it would be great to have more tools to do that, but the best thing of all is just to get lived experience patients into those universities. The second thing I wanted to mention was I've talked to an organisation in Sydney here in Australia about doing a talk by a rheumatologist about axSpA for GPs, and they record it and they do a podcast, and then the GP in their own time can go in and watch them and listen to them, and they get their CPD points that way. So it's 2 ways of doing things, just suggestions for you. Thank you very much.
Yeah, thank you, Annie. And you, Brenda? Not over to you.
Thank you. Just on the the notion of engaging healthcare professionals and family GPs in particular, for our back summit, we have influencers, so champions, similar to what was mentioned earlier by Dale, but we have champions who are inviting those GPs to our back summit. And the other thing is we wanted to keep it really simple. So the location of our back summit is on site at one of Toronto's downtown hospitals, which is really close to other clinics, physio clinics, health clinics, etc. So we wanted to make it really, really easy, and we're enticing them with a really good lunch and some entertainment. So we're trying to mix it up a little bit. From the CPD, or in our case, the CME perspective, by us leveraging an existing CME national virtual program, this organization already has the reach to all of the GPs and physios, et cetera. So really wanted to lean in to an organization that already had the connections, the lists, et cetera. So that was a simple way for us to engage. Thank you.
So if I may offer an insight from another type of project I've worked in the recent past with GPs, the community of GPs across Europe. It was an impactful project in the broader area of pain, and it was really helpful for them to have a kind of a scenario or pre-made scenarios of what it could be dealing with inflammatory pain or pain in general, and they could like be educated or pre-trained on those scenarios and maybe think ahead or have quick and easy referral pathways, just to have it really easy and spot it easier than before, and maybe think ahead and maybe use it quickly so they can like really spot it and really do referrals in an easier way. So with GPs, because they do have a little, I'm actually working in the primary healthcare system in Greece, and they only have a little bit of time and a vast amount of people to see every day. I know that's the case for many other states across the globe. That's not only a phenomenon in Greece. I'm really certain about that. So maybe if we were to focus on their training and awareness, but also giving them tools like pre-made scenarios, trainings that how to spot it really quick and easy, or maybe to think about it. Because when it's like when you hear hoofing, it's not always horses. It could be zebras or another like animal that's galloping. Maybe just give them ideas, quick and easy. It's this and this and this, and maybe do referrals. That's another way to approach this also with axSpA, and that's quick and easy for them to understand it also. They respond to it really well, because sometimes they just want the easy way out when it's daily clinical practice. Yeah. So Joe, please.
Hi, yeah, we have another question in the chat from Geraldine in the Philippines, and she says, which of the shared strategies are most scalable or adaptable for implementation in other countries or regions? And this is a big question for ASIF as well, and I think maybe maybe the three speakers, is there one small part that you think someone starting out to do this could really start with? Something, yeah, standalone maybe, or the first thing, or the most important? Any of you?
Any ideas from the presenters today?
I would say for the CSA, one of low cost, high impact, simple initiative was the CSA aligning with the already existing national virtual program that trains doctors. That was such an easy reach for us, and it was brand recognition, and it didn't cost us anything. It was just, and we co-promote the events with them. So, but that was very inexpensive and just a matter of a couple of meetings with a high reach.
Yeah, and that's reasonable. Also, you can use whatever set already in place. So yes, I mean, yeah, thank you for that. And Dale, did you want to mention something?
I think there's a lot. I think there's a lot that we could share. I want to resist the urge, though, to say, well, the answer is just to translate our resources and give them to you, because that's never going to be the answer. But
yeah.
Nevertheless, I mean, there are examples where those tools have been used in multiple countries. So, in Miranda, for example, they've used the symptom checker that NAST developed. And very successfully, it's based on the existing validated inflammatory back pain criteria that are internationally recognized, for example. So those are low-cost technologies that are easily applicable across multiple healthcare systems. I would love if ASIF could pull together the various national awareness campaigns that have been done, and just to see if there are things about underlying principles, not the collateral. The collateral will be culturally specific sometimes, but just to see if there are some underpinning principles, that will be a really interesting piece of work, I think.
Yeah. And after all, this is kind of the idea and the concept of the present webinar. I mean, exchange ideas, you showcase what you do actually, and I mean, for example, the members can also get inspired or maybe reach out, and we can like bring the both of you together, and maybe you can. I mean, that's the whole concept of what's happening here. I mean, yeah. So thank you for that day, and yeah. So anybody with another question? Because I do have a remaining one, which I would like to ask the three presenters or whoever else. And we are talking about HCP awareness and bringing them like closer to the axSpA realities and whatever is happening. And what was the biggest barrier you've come across with when talking not only to GPs but anyone who's seeing and meeting with patients with axSpA? Like, what was the biggest barrier, the biggest difficulty you've met with? No difficulties, no barriers?
Nadia, for me, it was this. So when I joined NAS 8 years ago, people would talk about diagnostic delay as if we should just accept it. It's always been 8.5 years. It's always been this way. So the biggest obstacle was rejecting a narrative which said you have to normalize long diagnostic delay. And that's why when we launched our program 4 years ago, it was deliberately trying to be transformative. And the idea that a gold standard of 1 year only came about because we led a national consultation process with HCPs and patients and professional bodies. So then when invariably some people said, oh, you can't achieve it, at least we could say we've done a national process, and people think, yeah, it's a real stretch goal, but it's a stretch goal worth having. So I think just disrupting the narrative that you have to accept long diagnosis for us was the most significant part of it.
Wow. So resisting change inherently. Yeah. Wow.
And for us in Canada, So I always say, you know, we're competing against other really important diseases, and some are really urgent diseases. So how do we compete in a sense? How do we get on that radar? How do we create that sense of urgency around this disease where there's so little knowledge? And so awareness is a big part of what we're trying to do right now, right? How do we get them to prioritize this?
Yeah. That's always a matter of discussion among the axSpA community, I think, globally. But the numbers talk really a loud case for us. But yes, that's correct. Yeah, but we still need to keep pushing. And as Dale said, resistance is always going to be there. Yeah. So I think we've just hit the point that the time is up. And I need to thank the presenters for a lovely webinar today. The presentations were amazing. They're going to be uploaded in the ASIF website. And I really thank everyone for being here today. And Joe DeBry and Joe Davis for facilitating and helping me with the questions and the organization of this webinar. They are always doing their best. They're really great. And thank you for being here today with us. And we hope to see you really soon again in the next webinar. So very nice seeing you. So bye.
Thank you so much. Thanks.
Cheers, everyone.
Much. Bye.
Thank you so much.
Thank you very much. Bye-bye.
Bye.
Thank you.
Nice to see you,
Lovely
Annie.
to see you, Annie.
Bye.
Bye.
Sending hugs from Panama. Ciao.
Hi,
Bye,
Rich.
Marcia.
Hi,
Bye,
Marcia.
Richard.
Bye.
Bye-bye.
Take care. Bye.
Bye, Marcia.
How'd it go?
It was good. It was really good.
Stop
How are you?
recording.
How are you? Yeah, stop.
Yeah.
Well, it was really weird. It was very quickly at 40 odd minutes, the recording. It says 1 hour 40 now on my thing.
It does. Why? And it won't let me stop the recording.
Isn't it?
Did you have to restart it?
No.
Oh, stop recording. There you go. No, it's okay. Stop.